Today we're going to talk about interventions that we're going to develop for the particular nursing diagnosis that we've already done. Okay, there's a couple of things that we need to start talking about before we actually write down our interventions. And that's, where do you get them from? Does anyone have any idea where you get an intervention from? Right, our Dungies, our books, plural. We get them from Dungies, we get them from our Potter and Perry, we get them from our Delmar Skills book. You can get them from lectures, from faculty lectures. You can get them from the common and care plan books that you might have bought. The common problem, though, when you guys look at them, is they are written for the general population with whatever that diagnosis is. And you have to take that intervention and personalize it to your particular patient. Okay? So you get the interventions from somewhere, not the air, not your head, because you guys don't have that knowledge base yet, but you've got to get them from some scientific source, and then you personalize them to your patient. Okay? Now there's a few things that you also need to look at when you're doing these. First thing students say to me, well, Lori, how many is enough interventions? Anyone have any idea how many would be enough? Can you give me a number? 5, 10, 15, 20?
5 to 10. As many as you need. Diagnosis you have on what patient.
Okay. I can't stand here and give you a number. I can't say 10 is enough. It's however many it takes to get the job done. That's how many you need. One thing that you guys can do in order to maybe kind of guess how many you need or figure out how many you need is if you take that care plan after you do it and you give it to one of your peers and you say to that peer, how does it look? The peer says to themselves, could I take care of this patient looking at this plan of care? Could I safely take care of the patient? That's how specific these have to be. They're tedious in their patient orientation. They're oriented to whatever that problem is of that patient. So how many you need in order to get the job done is how many you're going to write. Okay? Give it to one of your friends and have that person tell you if they could take care of that patient by reading that care plan. Okay? All right, now I have a couple gifts for you for our first interventions, because there's some things that are going to be almost universal that you're going to need. I have a bunch of words here. Interventions start with a verb, an action. Okay, they all start with an action. And I've just been, over the last 8 groups that have gone through, I've just been throwing up words as we use them. So these are words that we've actually used in our care plans. These are not all inclusive. There are many, many, many more, but it gives you a start. Okay? There's a couple of them that you'll always have on your care plans. Always. Can you look at this list and tell me?
Ambulate.
Well, ambulate is going to be for an ambulation. Educate. You're always going to have an education intervention. There's always something you can find that you're going to teach your patient. You're always going to have some assessment before you develop the care plan further. You've got to do some type of assessment. It's going to be particular to whatever diagnosis it is. All right? So let's start to work on our problem. You notice I didn't put all of the first columns, the basic human need and the objective and subjective data. I just left those off just for time's sake instead of me writing all those, because you guys have them on your care plans, right? Why don't we look at the mobility impaired problem, nursing diagnosis? Because I think everybody has that one most of the groups have that one. It's right there. So in your diagnosis, it would be mobility impaired. And you guys have got it all written out, right? I'm just going to write mobility impaired. I'm not going to write the whole diagnosis that you have down there just for time's sake. But we all know that we're talking about mobility impaired. And what was our goal? Okay, now, faculty will be really happy if they were to pick up this sheet, your care plan, when you handed it in and there was interventions all the way down that list. They would feel really happy. Okay? Before they started reading them, they'd say, wow, this student put a lot of effort in to it. So I expect when I look at a care plan that that will all be filled in. There are many, many interventions that you can do for any single diagnosis. All right? What is the first intervention? What is the first thing that we do for a patient before we even do anything? Before we even do an assessment? What is that protocol that you guys do?
Initial protocol.
Initial protocol where you introduce yourself, you've looked at the chart and you've, done your research before you go in there. Initial protocol. For the first year of this program, that's going to be your first intervention. It's my gift to you. Intervention number 1, initial protocol. Okay? Now that initial protocol, if I said to you, what's initial protocol, you should be able to name me all of those initial protocol things. So there's what, 5 or 6 that we have? Okay? So you should know that. You're going to use that for the first year. The second year of the program, that's a given that you do all of those things because you're past that point. Right now, we have to know what you're doing and what you're thinking, so that's why that's up there. Okay. What's our second thing we're going to do? What are we going to assess?
That's the condition, the whole patient.
Okay, but we're just talking about mobility.
How much they can do and what.
Okay, well,
Range of motion.
we might want to assess range of motion. I think that's good. Assessing range of motion. Be careful when you guys do these that we're talking about mobility. That's the diagnosis that we're talking about. We're not talking about self-care deficit. We're not talking about comfort. We're talking about mobility. We'll deal with those other issues in other problems. Right now, we're just doing mobility. How else can we tell if a patient's tolerating activity? Vital signs. So do we want to assess vital signs before the activity and then again after the activity? So that's another assessment. Okay, assess vital signs before and after ambulation. I just abbreviate everything, you know me. Learn your abbreviations. Okay. Now, remember when we were clustering our data, we had specific things that our patient had that we had to put on before he was ambulating? What were those? The sling, and what else?
Cane.
The gait belt we're going to need to put on, yep, but we have,
Cane.
what about the splints, guys? The splints are there for support. Okay, so we want to apply, and where were they? Right leg? Left leg? Someone look it up and see.
Right.
Right?
Yeah.
Right leg and right arm, right? Okay, so apply right leg and right arm splint. Apply right sling. And actually we have to put right arm sling. And I heard someone say about the gait belt. Apply the gait belt. Okay? So we've got, now we're down to 6 interventions and we haven't even gotten this gentleman out of bed yet. Okay? Tedious, specific to our patient. In your book, you might see these, they're said to be apply assistive devices. That's what it might be called there. And we've taken what we found in our book and we've personalized it to our individual patient. Okay, big difference between saying apply assistive devices and apply splint specifically to what limb, apply slings, apply gait belt. Okay. Number 7. Our guy is hypertensive, right? What are we going to want to do when we sit him on the edge of the bed?
Check for orthostatics.
We're not going to necessarily check for orthostatics, but do we want to go from laying to standing? And
No.
No.
You're gonna let us sit
Go
there.
we're going to dangle him. It's called dangling. Okay, so we're going to dangle patient, and we're going to personalize it, so we want to say a time frame, right? So we're going to personalize it to dangle patient times 1 minute. Right? Sound good? We could do more, depending on the particular patient. Okay, so now we've got him sitting. What are we going to do with him now? Okay. Well, we're going to definitely want to make sure he's sitting in the right position, but really we're going to stand him up. Okay? And what are we going to have with him? What's he going to walk using? What kind of cane? Quad cane. So let's say stand patient. Where's the quad cane going to go? Where?
On the side.
Left side, right side? What side is his?
Sling's on his right side, so it's on his left.
Okay, so it's going to be left hand. Patient stand left hand to hold quad cane. Can you see where we're going? You could take this care plan so far, hand it to a peer, and they could get your patient to stand safely. Okay? Big difference than just saying, stand the patient up. Okay? It's tedious in this first year, but you guys, we have to get you thinking. We have to know that what you're planning on doing with your patient, and you need to know before you go in what you're planning on doing. Okay, number 9. So we've got our patient standing. We're going to walk? Yeah. Okay, so we're up to the ambulating, right?
Do you want to talk to him at this point?
Well, you've been talking. Hopefully you've been talking to him right now. Hopefully you've been talking to him.
Assuming that he already has his oxygen on since he has to be on the
Oxygen, yeah. We forgot oxygen. Good point. So where should we have put that oxygen on him?
Right after initial protocol.
After range of motion or?
Right in here, maybe? So we can just throw it in here as a 3.5, maybe. Apply O2, 2 liters nasal cannula via portable tank. Okay, because he's got the O2 on. We just want to differentiate that we're putting the O2 on him with the portable tank instead of the stationary tank or from the wall, because we're going to be moving. That was a really excellent pickup. Okay. So we're standing now, we're going to move, right? We're going to ambulate him. Who's going to be with him?
You.
Me.
No, I mean, whoever's working on the aid
Right.
system.
The student. Who's going to be following?
You?
A peer with a wheelchair. Okay, let's write that all. Yes, ma'am.
We need to make sure he's not in pain at this point.
Do we
make sure he's
have-
comfortable?
Do we have any, I have no problem with that, yes. But do we have any evidence that he has any kind of pain at all when he's moving, when he's walking?
No.
From the case study, there's really nothing.
But if you're putting his splints and stuff on him, when you want to make sure at this point before he starts to walk, they're comfortable, they're not rubbing or, maybe I'm reading too much into it. That's okay. That's fine.
I think that kind of goes without saying that you're going to make sure that they're on appropriately when you're applying them. I mean, if we want to add something, we can add something to these. We can, add it after check for comfort. We can add that. I don't have a problem with that. You're right. That's something that you would do. Definitely. Okay, so we're going to walk him. We're going to ambulate patient with quad cane. We already know where the quad cane is. What side are we going to stand on? Okay, standing on right side, followed by peer with wheelchair. Okay? Specific to our particular patient. This might not be what you do with every patient that you have, but it's specific to this patient. And that's really what I'm just trying to drum into your heads, that it is specific to our patient. The ones that you're going to see in the book, like I said, they're global. They're for general patients that are moving. Okay, number 10. How far are we going to ambulate him? You know, we didn't say in that intervention how far he was going, so we need to put how far we're going with him. So we're going to ambulate 150 feet. Let's just add that in there. Sorry, we forgot that. That's why you do these in pencil. Make your life easier. Okay, so number 10, he's walked his 150 feet. What are we going to do? Stand in there in the hall?
No, sit him, no. Assist him, sit him down.
Assist, yep. We're using those verbs. Assist patient into wheelchair. Yep. Are we just going to leave him there in the wheelchair? Walk away? What do we want to make sure he's comfortable? What else?
Check his vital signs, right? Because you want to see how.
We have that there, before and after.
Oh, okay.
Do we want to make sure maybe that he's
Breathing?
safe?
Yeah,
We want to make sure he's
breathing.
alive.
Yeah. But then,
Check for safety. What are the kind of things that we're going to do for safety?
When he sits instead.
you get a table in front of him.
Okay. Apply safety measures. Now, can I just leave that as that? Apply safety measures? Yes, this is a global statement. We're doing specific to our patient. So let's say A, let's see, apply foot rest. Yeah, foot rests. If he had like a chair alarm, or if he had a Velcro strap, or if he had
Lap buddy or something. Yeah.
a lap buddy, we would have to put it there. We know that he doesn't, but we do know that we need to make sure that the call light is in.
Call light and reach.
Yeah, call light in reach. Okay? Okay, so we've got him safely sitting. Yes, ma'am.
When he's sitting, do you want to also make sure he's sitting properly, whereas the body mechanics part of it, like sitting up erect and.
So under assist patient into the wheelchair, you want to put some subcategories in here?
Yeah. Like
What kind of subcategory? What do you want
make
to
sure
say?
he's not sitting on his coccyx, or make sure he's not, you know what I mean, for pressure also reasons.
Okay, but we're getting into a different problem. We're in mobility. But see, that's good, because you're going to address
Right.
your skin issues in that skin integrity problem.
Okay.
So we'll talk about, when we do interventions for the skin integrity, we'll talk about all those things of making sure all the devices that you use so that he doesn't. That's very good. Thanks for bringing that up. Yes?
Yeah, I was wondering whether while we're ambulating him, we should be monitoring for his activity of tolerance.
Okay. So we're going to do specific things when he's what are we going to do specifically?
If he's grasping for.
Okay. So you want to put under 9, this is why we do these in pencil, assess, so we'll put it 9.5, how's that? Assess patient's tolerance during ambulation, right? Too global, we've got to make it specific. So what are the things that are going to tell us while we're actually moving with this patient if he's tolerating it? Okay? So we're assessing patient for tolerance. Check pain scale if you want. Check for shortness of breath. check gait. Sure. Anything else that you want to add up there? That's fine. I mean, you might think of something afterwards, so we'll just leave it up there.
Would he have problems with his breathing even if he has his oxygen on?
Sure. If you're seeing problems during activity, you might see shortness of breath even if they have oxygen, if it's too much for him. Because remember, our goal is higher than what he's actually doing. He was actually walking, what, 100 feet? So we're 50 feet ahead of time. So any kind of assessment that we need to do during his ambulation to make sure he's okay, that's a really good pickup. And that's why we do him in pencil, so we can add. Okay, so we've got him sitting in the chair. We've got him safe. What else are we going to do?
We take the vital signs.
That's up here. Yep. Okay, what is the other, besides the assessment in every intervention, or in every care plan, what is the other?
Talk to him, educate him.
Inform him
Educate.
of what.
Educate.
Educate.
Yeah.
Educate. Now, the problem, okay, the problem with this educate, there's always something with every patient that you have, every nursing diagnosis, there's always education that you do. Always. You might not even notice that you're doing it, but you're doing it. I put educate patient right there. And I'm putting a colon. Okay? Before you go into clinical, you may definitely have an idea of what direction you want to go with education and what you want to do and help that patient to learn. If you know that before you go into clinical, because remember, these are done before clinical, write it in there. Okay? If you're not sure, you might have found out what the needs are from one of your peers who had that patient the week before. But if you go into clinical and you're not really sure before you actually take care of the patient, the education that you needed to do, just write educate patient, put a colon there. When you're in pre-conference and you're going over your care plans and you get to that intervention when you're reading them with your instructor and you say educate, but I don't know exactly what I'm going to have to do to educate. I don't know what their needs are going to be, but when I do, I'll fill that in. So when you're in clinical and you find out the piece that you're educating your patient on, then write it in. Okay, so leave a little space after that, but leave that as an intervention because you can fill it in after the fact. Because believe me, you don't realize how much education that you do, but you do educate constantly in clinical with your patient. Okay, so you'll just add that to it. And what's our last one going to be? What do we have to do after we do any kind of intervention? You're going to be evaluating all along. Document.
Yeah.
Now, you can't just say document. You have to say what we're going to document.
The insurance and that you
Outcome.
wanted him to do.
So we're going to document ambulation.
If you met his goals, right? His goal, which is ambulate 150.
Well, not necessarily if he met his goal. We're going to document the amount of ambulation that he did do. Because remember, we've set the goal.
Right.
In the real perfect world, you would sit down with your patient and mutually decide on the goals that you were setting for that patient. So we're going to document ambulation. Okay? You'd also document your vital signs, your tolerance, patient's tolerance to the ambulation. Questions on this one? Did we fill up the whole page with interventions?
Mm-hmm. Yes.
And it was relatively quick because it's tedious. You need to get specific on what you have to do. I would also suggest if you write really small, you write a little bit bigger. okay? Because we have older eyes. It's
I
easy.
wrote big, but I wrote too big.
That's okay. You can go to the flip side. You can go to the back side if you need to. Yes.
Do we have to do rationales?
Okay, rationale. Very good question. Some faculty have you write rationales. Rationales are the reason why you're doing a specific intervention. And you get that from wherever you get the intervention from. Some faculty have you write the page number that you got the intervention and rationale from. Because we have just about every book that you could possibly have, we have. And when we correct these care plans, we have books all around us. So if an intervention and rationale doesn't sound right, we can always look it up. So that's a faculty choice, and your clinical faculty member will let you know if you need to put the rationales written out or the page numbers. Okay? That'll be an individual choice. Any other questions? Okay, what is another problem that you guys have on your... Okay, when we look at these, let's start looking at that nursing diagnosis column, not the basic human needs column, but the diagnosis column.
Swallowing impairment?
You want to do swallowing?
Yeah.
That's a big one to do. Okay, swallowing. And what was our goal? Okay. Now a lot of this, you're going to have to rely on me for interventions because aspiration precautions are really particular to each individual patient. They're really specific, patient-specific. So a lot of them you're going to have to rely on just my knowledge base to steer you, unless some of you are out there working and have had patients who are on swallowing precautions, aspiration precautions. Okay, so what's our first intervention? Initial protocol, my gift. Okay, number 2. What's number 2? Assess what? Okay, well, let's talk about this for a minute. This is our problem. How are we going to tell if our patient has aspirated? What's probably one of the first things that you might see?
Coughing.
Choke coughing when they're drinking something, choking on it.
Okay, so we're assessing respiratory status, right? We're assessing maybe oxygenation, which would be how? Pulse oxes. Okay, so we're going to assess our respiratory system, and we have to be kind of specific. So we're going to say A, we're going to do pulse ox. B, we're going to do vital signs. You're right. Pardon?
Lung sounds.
Yes, absolutely. Lung sounds. Okay, now it gets a little tricky. Okay? For patients, there's, like I was saying, there's specific things really to that particular patient that we need to do in order to not have that patient aspirate. So we're going to maintain aspiration precautions. But can I just write that? No, I can't. I can't just write maintain aspiration precautions because if Ivan gave Ruby his care plan and I just put maintain aspiration precautions, that's not going to tell Ruby what to do when she takes care of this patient. So therefore, we have to be tediously specific on what we're going to do. So, does anyone know some things that we do for aspiration precautions? Okay, we do thicken liquids. So, we're going to thicken, and we know that we thicken our guys' liquids to applesauce, right?
No. So applesauce?
Yeah, it's in.
You put thicken in applesauce?
No, thicken to
Oh, I
applesauce
think you said you put
consistency.
thicken in. I'm like, wait a minute.
No, applesauce is what we want it to be.
Yeah, I'm
Want it
like,
to get to.
Is that the same as nectar?
Probably,
Or
yeah.
honey nectar. Is there
Honey.
There's different consistencies of the
Right.
thickness that they want.
Right,
I guess depending on how they swallow or how.
right, absolutely. So every patient is different. Yes.
It's going to be.
Okay, B, what do we want to do?
The upright sitting position.
Right, we want our patient out of bed for meals. So out of bed, in chair for meals. Okay, we want him out of bed in the chair for meals. When we get him back into bed too, do we want to put the bed flat?
No.
No, so we always want our patient's bed to be elevated, let's say 30 degrees. Okay, so head of bed elevated 30 degrees at all times. Yes, Ivan.
Then you want to have the suction equipment on standby just in case.
You're absolutely right. Suction equipment available at all times. We're going to have somebody there to use it. We're going to have somebody there to use that suction equipment when the patient's eating. So we need one-to-one supervision for all meals. Right? Okay, what else are we going to do? Let's see, out of bed, head of bed up, thicken liquids, suction equipment. Yes, yes. So E, we got F. Patients who are on aspiration precautions, a lot of times they have to turn their head a specific direction when they swallow. And then after they swallow, they have to cough. Okay? Specific to each patient. So we'll just say our patient has to turn their head. Which way do you want to go?
Right.
Turn head to right for swallowing, to swallow. And then can we go ahead and say that we want our patient to cough after swallowing? Anything else?
Yeah.
What else?
Encourage the patient to take in small amounts of food at a time.
Encourage small amounts,
Small portions.
small portions. Chew thoroughly. Okay, anything else that we want to do? What happens a lot with patients who have paralysis? Does anyone know what happens in the side of the mouth? They pocket food. Yeah, so we want to make sure that there's no food pocketed. So we're going to check, yeah, for pocketed food. Okay? Check for pocketed food. Okay, is that good for our aspiration precautions? Do you want to, anything else we want to add to it? I think that we've done pretty darn good job for that. Okay, so number 4. What else do we want to do? We've done our initial protocol, we've done our assessment, we've done our aspiration precautions. What's the other one that we have in all of our care plans? Educate. Now, we could educate our patient.
How to take in small amount, how to swallow,
Right.
how to turn head.
Right.
remember to do.
We could educate him and remind him of the specific things that he has to do for those aspiration precautions. We might not know when we go in there exactly what our needs are going to be, but I think that pretty standardly we can, with an aspiration or swallowing problem, we're going to have to remind them of what to do. So educate patient on aspiration precaution. And you might want to wait because there might be specifics that you want to put in there that you've had to do with your particular patient. And then what's our last thing? What's our last intervention? Document. What are we going to document?
The goal.
Okay, so we're going to document that our patient was free, or can we write that they were free from aspiration, or can we just write, are we going to document our aspiration precautions, our aspiration, how do we want to word it? How about their tolerance to precaution, to aspiration precautions? We could document their adherence to aspiration precautions. We could document whether or not they've aspirated. Okay, there's,
Has not aspirated on my shift. Could it be
well,
something like that?
yeah, well, this is, we probably want to write how we've identified that our patient hasn't aspirated. Okay, by, you know, all of the assessments that we've done. You might want to do some post-assessments, you know, post-lung sounds. Okay, make sure they haven't coughed. It's tedious, but, you know, they're specific. They really are specific to your patient. You can't just take a global intervention that you get from your book and write it down. You've got to take that intervention and make it oriented to your patient, okay? Specific to your patient. Okay? Everyone okay with that? The next thing I want you guys to do for next week is just through the week, give it a try. You've got another nursing diagnosis there. Write the interventions yourself. Give it to one of your peers and see what they think. If they could take care of that patient, always keep in the back of your mind, when you're writing these interventions, could I give it to a peer, and would that peer be able to take care of that patient safely reading these interventions? Okay? Give it a shot.